Hello, everybody. I have the pleasure to introduce these new IHCH journal clubs, and we have the pleasure to have here today Dr. Giorgio Orofino, that is working in the hematology and bone marrow transplantation unit in San Raffaele Scientific Institute in Milan, Italy. He is going to discuss a very exciting clinical case of a second allogeneic hematopoietic cell transplantation as salvage therapy after CAR T-cell in high-risk acute lymphoblastic leukemia. As expert, we have Dr. Simona Piemontese and Dr. Annalisa Ruggeri. So we'll have some very exciting discussion at the end of the presentations. You can ask your questions, send your questions through the chat during the presentation, and we will try our best to take and answer your question with Dr. Orofino and the expert. And now you can go on. Giorgio, please start.
So good morning to everyone, or good afternoon, depending on where you are. I really want to thank you for giving us the chance to present our case in this IAC Journal Club. I want to thank Simona and Annalisa for the clinical case and for this presentation that we worked on together, and Professor Malard, of course. We're back in 2016 in Romania when a female 25-year-old patient accessed to the emergency room for progressive asthenia. Here, you can see her blood tests at the moment of diagnosis. An immunophenotype performed on peripheral blood and then confirmed at bone marrow represented the presence of blasts, 81%, positive for CD19 and negative for CD22. At the bone marrow aspirate, we confirmed the presence of blasts, 97%, and the only FISH performed was the FISH for the chromosome Philadelphia that resulted negative. Unfortunately, at the moment of diagnosis, no cytogenetics nor MRD probe sequencing were performed. Indeed, colleagues from Romania had a diagnosis of acute lymphoblastic leukemia Pro-B, Philadelphia chromosome negative without involvement of central nervous system. The patient underwent first-line chemotherapy in Romania according to the MRC protocol, a pediatric-based approach, that was unluckily interrupted at day 16 for a septic shock and required immune support and intubation. Subsequently, the patient was transferred to our hospital in San Raffaele in Milan in March 2016. We assessed our first completed remission at the bone marrow evaluation. We decided to go on with chemotherapy according to the Italian protocol inclusive of intrathecal prophylaxis. We indeed complete 3 consolidation cycles, and we assess a complete remission after all of them. At that stage, we decided to propose to the patient, since she was very young and fit, and we were not able to assess her MRD status, an allogeneic hematopoietic stem cell transfer. But the patient refused. Indeed, we have to say that at that stage, the patient had a poor treatment compliance. That's a very common feature among adolescents and young adults with acute lymphoblastic leukemia, but in general, with cancer diagnosis. Very unfortunately, in January 2017, the patient had a relapse. Indeed, we had a bone marrow evaluation that expressed the presence of 43% of blasts, again positive for CD19 and negative for CD22. We performed cytogenetics, that was normal, and we sequenced MRD probes at that stage to further follow up the patient. We decided to proceed with blinatumomab, but unfortunately, after 1 cycle, the patient had a progressive disease with a very high amount of blasts in bone marrow evaluation. Subsequently, we decided to go on with a reinduction chemotherapy, again according to the Italian acute lymphoblastic leukemia chemotherapy protocol. And we were able to assess a second complete remission 2 months after induction chemotherapy with an MRD positivity. We decided to move to the allogeneic stem cell transplantation. In June 2017, we used peripheral blood stem cells as graft source. Here, you can see patient characteristic at the moment of the transplant. She had a performance status of 2, and the disease was in second complete remission with an MRD positivity. Here you can see also the donor characteristic, a mismatched unrelated donor from the registry, a male, a young, very young male, 27 years old, with a major RBO mismatch. An HLA match of 9/10 with an antigenic mismatch on HLA-B. In this slide, you can see our conditioning protocol we use at the moment of the transplant, based on 3 drugs, treosulfan, tiotepa, and fludarabine at the dosage. And then our graft versus host disease prophylaxis, which is in our center based on PTSI at this dosage, together with sirolimus and mycophenolate mofetyl in matched unrelated donor and haploidentical donors. The patient had as complication fever neutropenia, and neutrophil and platelet engraftment occurred at day 31 and 45. A full donor chimerism was assessed at bone marrow evaluation at day 30, and then was full donor also in the subsequent evaluation. We were able to withdraw immunosuppression by 6 months after transplant with no diagnosis of acute nor chronic GVHD. The patient remained in complete remission, the second complete remission, MRD negative, until June 2021 at all the bone marrow evaluation we performed after transplant. A full donor chimerism was assessed, and no chronic GVHD diagnosis was ever made. But very unfortunately, more than 5 years after transplant, so a very tardive phase, a second relapse occurred. The patient had a performance status of 2 since she was CRIP. Indeed, extramedullary disease with bone and pancreatic involvement was present. We performed a biopsy to the bone, confirming the presence of acute lymphoblastic leukemia blasts. Fortunately, no involvement of central nervous system. At the bone marrow evaluation, we confirmed the presence of blast, again positive for CD19 and negative for CD22. A mixed chimerism was present, and of course, an MRD positivity. You can see from that in that slide the MRI image of the leg of the affected bones, the tibia, the right tibia, and the PET in which is present the pancreatic localization of disease. We decided to move on with an early lymphocytopheresis for CAR T cell manufacturing, and then we proposed to the patient, as bridging to CAR T cell infusion, a chemotherapy-based approach based on methotrexate, cytarabine, intrathecal therapy, and tibial radiotherapy on the affected bone, 30 gray total in 10 fractions. So 1 month after chemotherapy, we evaluate bone marrow and the persistence of disease with 8% of blast, a mixed chimerism and MRD positivity, but also a light PET positivity was present, so high burden of disease at the moment of CAR T cell infusion. We use as lymphodepleting regimen fludarabine together with the cyclophosphamide for 1 day and fludarabine for 3, just as ZUMA-3 trial protocol. We then infused CAR T cell, an expanded access program. We had access to the Tecartus cells since they were not administered by the Italian drug regulatory agency. The CAR T cell infusion was relatively well tolerated by the patient. She only had a diagnosis of cytokine release syndrome G1 with a fever that compared at day 8 without hemodynamic instability nor oxygen requirement. We administered to the patient 72 hours the onset of fever, tocilizumab, the first dose, and 12 hours later, the second one. No ICANN syndrome was detected, and the I-score was persistently 10/10 in this patient. The patient was then discharged at day 23 after CAR T cell infusion with a full hematopoietic recovery, and we administered, as per national guidelines, the SARS-CoV-2 prophylaxis with tixagevimab and chilgavimab at the prophylactic dose. In this graph, you can observe the CAR T cell in vivo expansion. The peak of expansion occurred at day 10, which is the right timing of the CRS onset. CAR T cells were still detectable in peripheral blood more than 90 days after CAR T infusion, and persistent B-cell aplasia was present for this patient. More importantly, 1 month and 3 months after CAR T, we assessed a third complete remission with an MRD negativity, a PET, and a CT scan negativity, That's suggesting a very high efficacy of CAR T cells in treating also extramedullary disease in the case of acute lymphoblastic leukemias. But sadly, 5 months after CAR T cell infusion, at the bone marrow evaluation, a third completed that we routinely perform in our patient after CAR T cell infusion, a third completed remission was assessed, but the MRD started to become positive. Indeed, the patient had a molecular relapse, and for us, we promptly gave indication to second allo for this molecular relapse indeed. We did not consider to treat with inotuzumab since the patient was CD22 negative at the diagnosis, but also at further relapses. And we decided to use blinatumomab as bridge to second transplant, considering that although no efficacy was assessed in the first administration of the drug, an allogeneic stem cell transplantation occurred between that moment. So we considered that a possible potential activity of the drug may be considered, but we had to interrupt the treatment at day 10 for neurotoxicity. At the bone marrow aspirate after blinatumomab, we confirm a third completed remission with an MRD positivity, so no evolution of disease at the moment. And we decide then to perform the second allo, more than 5 months after CAR T cell infusion, again using peripheral blood stem cells as graft source. At the moment of the transplant, the patient had a performance status of 0, and the disease was in third complete remission with an MRD positivity. Here you can see also the second donor characteristics, another mismatch, unrelated donor from the registry, again a young male patient with a minor ABO mismatch. Please note that also the donor was vaccinated for SARS-CoV-2 at the moment of donation. Here you can see our conditioning regimen we use for the second transplant. We consider to introduce TBI into the conditioning at the dose of 10 grays over 3 fraction combined with fludarabine at that dosage. Again, this is our GVHD prophylaxis protocol backbone based on PTSI. But then, at the moment of admission to the transplant unit, the patient was SARS-CoV-2 positive. She was totally asymptomatic with a normal pulmonary CT scan. So, how to deal with COVID-19 and allotransplant? In our case, the patient, but also the donor, already received 4 doses of mRNA SARS-CoV-2 vaccine, so a full vaccine protocol. We have now at our disposal tixagevimab, chilgavimab, the antibodies that we administered that timing at the therapeutic dose, together with remdesivir, the antiviral therapy, before starting conditioning regimen. Of course, we have to take into consideration a risk balance between a very aggressive leukemia with high risk of recurrence and a potential SARS-CoV-2 infection. We decided to go on with the transplant. Here you can see sum up all the characteristics of the second transplant. The patient was, as I said, in third completed remission with an MRD positivity before starting conditioning radiochemotherapy. And she was positive, even though at a low viral load for SARS-CoV-2. We administered the antibody, tixagevimab, chilgavimab, together with remdesivir, and then we started conditioning chemoradiotherapy, and we administered PTSI after transplant. As you can see here, the viral load rapidly increasing, and that's that's due basically to the high lymphotoxicity of conditioning chemoradiotherapy, but also of PTSI. Very surprisingly, but similarly to a patient we treated only 1 month before, at the timing of neutrophil engraftment that occurred at day 33, COVID-19 symptoms occurs. It was mild symptoms, only rhinorrhea and fever, and when symptom finished, the SARS-CoV-2 positivity started to decrease until a negativity that occurred at day 17 after transplant. For the second transplant, the patient had a diagnosis of acute GVHD, a grade 2 overall, with a skin grade 2 and a gut grade 1, treated with steroid at 1 milligram kilo, with a complete response and a rapid steroid tapering subsequently. More importantly, at 1 month and 3 months after the second allo, the patient was in third completed remission with an MRD negativity. So, in conclusion, CAR T cells are a versatile therapy in acute lymphoblastic B leukemias, also active in extramedullary disease. MRD monitoring is crucial, and a rapid intervention is required when MRD positivity comes out. Second allo should be considered in very selected patients with very high-risk diseases. Of course, we have to assess which is the role of allo after CAR T cell therapy. We used to, in this case, we did the allo in MRD positivity, but of course, there are trials that try to see what happens when allo is performed without MRD positivity in the case of acute lymphoblastic leukemias. We could consider for the future also subsequent CAR T cell infusion due to the fact that very high activity is assessed, also considering potential new targets if antigen loss is detected. If antigen loss does not happen, we could also consider these specific antibodies to rescue CAR T cell activities. And finally, how to deal with very high-risk patients with SARS-CoV-2 positivity. We have now at our disposal passive immunotherapy with antibodies and antiviral therapy that may render allo, but also other cancer treatment in patients with mild or asymptomatic SARS-CoV-2 infection feasible, in case, of course, of transplant urgency. I really want to thank our team, the bone marrow unit at San Raffaele Hospital and Professor Fabio Ciceri. I want to thank you for your attention, and these are my contacts if you want to if you have some questions about this patient and this clinical case. Thank you.
So thank you very much, Giorgio. Maybe you can just leave the screen. Yes, stop sharing the screen.
Oh, sorry.
Yes, so we can have the camera.
Yes.
So thank you. It was very interesting case. So again, do not hesitate to send your questions through the chat for Giorgio and from Annalisa, Ruggeri and Simona Piemontese if you have any questions. So, and I will start with a first question, Giorgio. You say that we should discuss second allo in patients with acute lymphoblastic leukemia. Do you have an idea in which patients are eligible for such treatments?
Okay, so second allo is an opportunity, of course, for patients with relapsed disease. But of course, we have to consider second allogeneic stem cell transplantation risk. First of all, we have to assess if the relapse is a tardive relapse or very premature relapse. We have a threshold that is about 6 months, considering after 6 months, a tardive relapse that may be more sensible to second allo. But of course, before proposing the second allo, but I would say also before proposing the first one, a very careful exam of the patient status, considering all the score of the transplant, in particular the SORRO score, but also the ABMT score is very important to assess if the patient may receive the second allogeneic stem cell transplantation. There are actually no really guidelines about second allo, but national societies start to say what they think about the second allogeneic stem cell transplantation, and they all agree that the performance status of the patient is central to proceed with this procedure.
And so this raises some other question, because you can use second allo, but why not use DLI from the first transplant if we have an answer for 5 years? This is the first question. And the second question is, what are you going to do with the donors? Are you going to use the same donors, or are you going to look for another donors on APLO? What?
Of course, DLI was an opportunity we take into account. So I think that is not the right answer to that question. Of course, it was a possibility. The important before administering DLI is to exclude an HLA loss relapse that, even though infrequent, may happen after mismatch unrelated donor. So it's very important to exclude, and we did to that patient, and she did not have a HLA loss. But of course, it's something we have to consider about. What about the donor? It's another very difficult question. There are, again, no consensus about the same or the second donor. There's a clinical study that tells us that maybe the same donation from the same donor may be associated with an acute GVHD of higher grade if compared to the transplant done when a second donor is obtained. there are some association between leukemia recurrence and change of donor, considering that, of course, a second donor may reduce the leukemia recurrence rates. Of course, these are very difficult questions to answer. And of course, it was easy in our case because the first donor was not available. So we had to go with the second one.
Yeah. So yes, thank you. And I think that to check for the HLA loss is very crucial. The last two patients that were transplanted with APLO, when we check for them, there is an HLA loss for both of them. So it's not. We have a lot of patients in this situation. So before doing DLI, we really need to check on that. I don't know, Annalisa, regarding the choice of the donors, do you have any recommendations? Are you going to use more an APLO if you have an APLO, or you are going to have some more HLA mismatch?
Thank you, Florent. As you said, this case is very, very interesting because we had a very late relapse. So the choice of proceeding with the second transplant, it was really a matter of debate. And in our center policy, in general, we prefer to change the donor. However, we have to say that there is no clear indication that there are not so far studies available on the different outcomes among the use of the same donor or choosing another one in that case. We had in Italy the possibility to proceed with this very fast enrollment of even the unrelated donor, and this is the reason why in having a very well type 9 of 10, we decided to proceed with the mismatched unrelated donor. But it's true that in such kind of high-risk disease in which the possibility even of performing post-transplant maintenance or post-transplant immunotherapy with DLI, the choice of an haploidentical transplant would have been of interest, of course.
So there is still some open question regarding this, but at least there is no, in this situation, it seems to be really a good idea to proceed with the transplant. And regarding that, we have a question. So we are going now to move, yes, to the place of the allo after the CAR T cells. So I will ask to Giorgio and also to Simona after, when do you think we should perform some allogeneic stem cell transplantation after CAR T cell? If you are the patient, if is complete response, we go to the allo, or we are going to monitor the minimal residual disease and perform the allo at that time. So what is the opinion first, Giorgio, and after Simona?
Okay, again, I think that's very changing procedure in this period, in this timing. So we have many data that are coming out very rapidly. What I think that allogeneic stem cell transplantation in acute leukemia may have a role to consolidate CAR T cell that very frequently may be a very good bridge to allogeneic, but for very aggressive disease with isogenetic characteristics of aggressivity or molecular, of course, characteristics, may render allo, of course, I think the better solution to consolidate the response. Of course, also considering different CAR T cell products, because in pediatrics we have approved Kymriah, which is for 1BB as a costimulatory domain, and in adults we use the Cartus, which is CD28 as a costimulatory domain. Also, different drug products have different timing of expansion and persistence. So I think that we have to consider the allo after CAR T cell infusion, also based on the characteristic of CAR T we infuse.
And what is your opinion regarding that, Simona?
Yes, the answer is not unique. So what happened at our center, we discuss patient by patient how to proceed after CAR T cell infusion. As Giorgio has told, the high-risk profile of the disease will be an indication to consolidate with an allogeneic transplantation, above all if the patient hasn't received yet an allogeneic transplantation. Okay. Other criteria that would be in favor of an allogeneic transplantation as consolidative therapy are the high MRD positivity in flow cytometry before CAR T cell infusion, extramedullary disease, and of course, as Giorgio told, the type of co-stimulatory molecules that we use. We have no studies, we have no studies that have been performed to study the meaning of the consolidative therapy with allogeneic transplantation after CAR T therapy. So even in the prospective studies in CAR T therapy, the use of allogeneic transplantation was a clinical decision. Okay, so different patient by patient. So there is not a randomized trials that can give us a unique answer in this sense. But we have studies from adult patients, for example, by Slow Kettering in New York, that demonstrate a 68% of relapse in ALL-B adult patients that receive CAR T therapy. So in these patients, an allogeneic transplantation will be an option. In other studies, we have an improvement of event-free survival that still is limited in patients that receive only CAR T therapy, but not on overall survival. But this could be a problem of follow-up, a short follow-up in order to see improvement in overall survival, and will, of course, also depend on the transplant mortality that the center have with allogeneic transplantation.
Yeah, so this is really a complex question on which not just a single answer. This is what we see, and of course we have to decide based on the disease characteristics, of the minimal residual disease, and of the availability of the donors, and of the patient's history, of course. And we have a very specific question in the chat that asks, for patients that receive CAR T cell in complete response after failure of a first transplant, how many patients receive a second transplant in your centers? I don't know, Annalisa, if you have some data in the registry regarding that, in patients that receive allo after CAR T cell, in particular in second complete response. You are off, you're on mute.
Oh, sorry.
Go, Giorgio, and then I can complete.
I think we treated 2 patients with CAR Ts after hematopoietic stem cell transplant. One of them is the patient we're discussing right now, and the other one is still in complete remission. No, 2 patients in complete remission after CAR T cell MRD negative. One is a longer follow-up period, and the other one has been treated a few months ago. So 2 patients over 3 in negative after CAR T cell infusion in our center in the recent experience.
Of course, we cannot have the specific question because the specific answer, because this is really a clinical decision that is taken considering the characteristics of the disease, the status of the patients, and also the compliance and the performance status, of course. In the registry, we have not yet this kind of information, but at one of the last survey that we have performed, we have seen that there is a continuous increase in the use of allogeneic stem cell transplantation as consolidation treatment after CAR T in pediatric patients. This has been already reported, and we have some data available in the ABNT. For the adult setting is more anecdotal, and it depends also on according to the transplant center experience.
Yeah, this is really something we expect to have some answer in the next years when people will perform more CAR T cells and have more expertise.
The growing experience will let us also knowing how to monitor the MRD how to monitor the also the lymphopenia and what to expect after like in 9 or 10 months, 12 months of B lymphopenia, and how to deal with this kind of complication.
Yeah, and in the case you presented, Giorgio, what was also very surprising, this is this COVID-19 stories, which you decide to perform the transplant with patients with the positive PCR, and it seems that you were lucky because at the end the patients did well. If you can comment regarding this, and if this is the first time you perform a transplant in patients that were COVID positive, or you have some other experience?
We had a very recent experience with another patient in acute lymphoblastic leukemia just in this summer, so 3 months before that one. The case was a little bit different because the transplant in that case was has been postponed for 3 or 4 times since the patient was a long COVID and she was positive for more than 4 months. So after 4 months and then MRD, they started to increase. We decided in that patient to perform the transplant because, of course, she had an urgency. So it's the second patient that behaves exactly the same in our case. And of course, we're more confident to perform the transplant since we have now at our disposal different drugs to exclude a very severe form of COVID. Indeed, antibodies, but also antiviral therapy may help us in deciding to go on with the transplant. In this case, we used to perform a SARS-CoV-2 analysis, and we try to look for the antibodies that were specific for that variant. So another important thing is to try the right therapy for COVID-19, and they're of course evolving too.
So you were lucky because right now, for the large majority of the COVID we don't have any antibodies that work. So yeah, you say that now we have some tools, but in fact, no, we don't have a lot of tool anymore because monoclonal antibodies doesn't work. So we still have the remdesivir that can be effective. And but another thing that can be useful, this is the use of plasma from donors that have COVID-19. Do you have some experience with the plasma?
For our patient, in this case, we try to have the plasma, but in Italy, unfortunately, we only had plasma from the very first period of COVID-19. So we have not the right plasma with the new variants, and so we did not perform because of they were against the first waves of COVID-19. So just in February in 2020.
It will not be effective.
But of course,
yes.
we look for plasma, of course, considering all the data that are out about convalescent plasma for patients.
So during the first peak of the pandemic, we used a lot. We had also an internal protocol on the use of plasma for our patients. But then, since the characteristics of the virus is changing really a lot, it is and the possibility of having the monoclonal antibodies was much more well structured. But of course, we have to think already at the new breakthrough that we can see with the different mutation of the virus.
Yeah, because now the monoclonal antibody don't seem to be effective anymore. So yeah, maybe you have to start again to look if you can have some plasma now for the next patients, because we have also some experience with some patients that have COVID-19, not at before we perform allo, but before we perform CAR T cells. One of them did well. We treated also with monoclonal antibodies right before, but the other one just go to it worsened the COVID-19 after the lymphodepleting treatments. He go to the intensive care units. It was very, very, very severe COVID-19. He recovered at the end. And it was right just between the lymphodepletions and the CAR T-cell infusion. So we have to delay the CAR T-cell infusion for 2 weeks before we're able to infuse them. At the end, he recovered and we are able to discharge the patient, but sometimes it can be very tricky because in these situations, what are you going to do if the patients go to intensive care units, have some respiratory support right before the stem cell infusions? So yes, we don't have some good answers. Most of the time, we just have to go to proceed because we have the high risk disease, and it was the same thing for us. In the case, this is a donor that is COVID-19. Do you have some procedure? Have you seen these situations?
We never had the donor. Indeed. We had one donor that resulted to be positive once the patient had already received the conditioning regimen. So we change the type of donor and we shift towards a cord blood infusion.
So we have also the same situation with the donor that was COVID-19 positive at the time of the stem cell harvest. So we take the stem cell, it was peripheral blood stem cells, the donor was asymptomatic, and everything did well because in fact we checked there is no COVID-19 in the blood of the donor, there is no viremia, and in fact it seems to be feasible. So maybe it is also some experience we need to share because it's maybe easier.
The administration of growth factor for the donor with COVID was also uneventful because this was something that was discussed at the beginning as a possible danger for the donor. So there are a lot of things to be taken in account, but again, sharing the experience is crucial for having very good results for our patients.
Yeah, we are really. This is why this kind of meeting is very interesting because we can see in our situations the patient we detect the COVID-19 after the use of GCSF, so we don't raise this issue, of course. So we are coming to the end. I don't know if you have some last comments, Giorgio, Simona, Annalisa.
No, I think what we can conclude also after this case, and it's the possibility, but we will need more time for it, is the possibility of performing a second infusion of CAR-T. This is there are already few reports sharing some experience, mainly in patients with lymphoma. Of course, this is also a matter of cost, so it's a more complex decision, but what we can really have as take-home message from our case, I think that my colleagues share with me this position, is that we really need to think always to give the therapeutical opportunity to our patients, proceed and be sometimes a little bit brave, but proceed with the right treatment and not stop to the possibility of performing a second transplant, even in case of very high-risk disease, but discussing case by case.
So
maybe another, sorry.
No, go, Simona.
No, another point, it is that we have to discuss the indication to consolidation with allogeneic transplantation very soon after transplantation, because the right timing could be 3 months after CAR-T infusion, so that we don't lose too much time.
Yeah, that's a very good point. So, Giorgio, last comment or?
Yes, what I think is just what my colleagues say, that's very important to proceed with treatment when a therapeutic opportunity is seen. And of course, in very young patient and selected patient, an allogeneic stem cell transplantation, as it was the case for the first time she performed, may be very efficacious in treating a high-risk disease that must be treated as soon as possible, of course.
Yeah, so thank you again, everybody. Thank you, Giorgio, Simona, Annalisa, for this very great meeting. And we'll have very soon another meeting for another clinical case, so just stay on. Bye.
Bye, thank you.
Thank you.
Goodbye
Bye.
to everyone.